But we must pay attention to multiple effects and multiple long-standing influencing factors. And so, as we continue to educate each other, we invite Dr. Nivirna Maharaj to discuss the psychological impact of child sexual abuse.
Good morning, ladies and gentlemen. I would like to share a poem, a trauma narrative that a 21-year-old female patient of mine, an adult survivor of child sexual abuse. My body no longer belongs to me. It is up for grabs. Literally, touch me and I won't blab. The hot water isn't enough. I can still feel your hands. I can still feel your touch. I can threaten to tell, but you'll just call my bluff. I still remember you stroking me that day. No matter how hard I try, I can't push it away. I'm filthy, disgusting, nasty, sticky like glue. Oh no, wait, maybe I'm describing you. Sometimes I want to break your hand, shatter your fist, when you reach out and caress me like a lover, but instead I freeze and become blinded by a mist. I can barely breathe, much less shudder. I'm the one in therapy? How is that fair? You're the one who's sick. I bat away your hands and you give me a glare when I put a stop to your perverted antic. I'll be ready next time and you'll be sorry for ever thinking my body belongs to you and not me. Everyone will know, and then what will you do? For I have the power of words, but what have you? So this particular patient had experienced extensive child sexual abuse at the hands of her aunt. And this was her trauma narrative. So a part of therapy is the final stages after we equip most patients, they're able to express their trauma, whether it's whatever form, whether it's art, whether it's poetry, and whether it's words. And so what I do for a living, ladies and gentlemen, is I sit with patients in their darkest moments. I sit through emotional turmoil. I sit through terrifying stories, healing, recovery. And I'm a clinical psychologist. I've specialized in treating children and adolescents. And I've worked extensively as well with juvenile sex offenders. So I've seen both sides of the coin. And I'm really passionate about this topic today, and I'm really, really immensely honored to be invited as a speaker to talk about this topic, because it really means a lot to me, and I see it in my daily practice in Trinidad. And this patient particularly was from Trinidad. And so I definitely want us to start off and sort of think about the implications, the psychological implications of incest, child sexual abuse. And I want to give to you as educators some indicators as to how to spot this among children, some red flags, and some recommendations. So very briefly, I want to talk about some child sexual abuse quick facts. So the peak age of vulnerability for child sexual abuse usually occurs around the age range of 7 to 13 years old. And this is because grooming is easiest at this stage. Oftentimes victims are most accessible for their relatives. And it's important for us to know that most sexual acts are committed by men, and in particular by persons known to the child. A lot of times patients come in, and parents in particular, because I do a lot of parent training as well when I work with child patients. But a lot of times, parents may sort of inform children about stranger danger, you know, and keep away from strangers. But in my experience, the majority of cases are really based on people who it was easy for these people to have access to these children. It was easy for them to groom them. And in most cases, it's people they know. Within most incestuous families, this is a very important variable that I think I want to raise a lot of awareness for. Marital violence, and domestic violence in particular, is the most stable and consistent variable that we see across research, that I see across experience. And that's something to take into consideration, because actually it is the same variable that we see among sex offenders. Sexual abuse among females has received significant attention within the research, within the media as well, but sexual abuse of boys remain less readily recognized and a lot less readily reported, in spite of its high prevalence, as Prof mentioned. So research studies demonstrate that, in fact, and this is sort of an alarming statistic, most mental health practitioners rarely even inquired about sexual abuse among male patients. So when we meet adult male patients, and very rarely are they asked, have you been sexually abused? And this is something that we have to change. This is something that we have to start doing better with. Because I've had several experiences where when I've asked patients, and when I've asked male patients in particular, whether I get a yes or whether I get a no, but my yeses usually are like, you're the first person who asked me that. And being able to have someone, because a lot of times people who are abused victims, they don't really share their story. If they are given a chance, they will. And to have someone ask them that is very validating. So, research shows that teachers who have knowledge, skills, and positive attitudes toward protecting children can really make a strong impact on the safety of their students. And in fact, most times, the referrals that I get are usually through a teacher who would have detected it. Because you guys sort of see a child as the whole child. You see several dimensions of them. Whereas parents spend a lot of time, yes, but you guys spend a great deal of time with these kids, and you see them on multiple levels. And I want to commend us for this, the recognition. So due to the nature of incest, the belief of limited resources, and the current rape culture of our children, and that the children coexisting currently, children and adolescents are often, especially kids who experience incest, usually, most people think they would have experienced symptoms of PTSD or post-traumatic stress disorder. And most people have this misconception. But children who are experiencing incest, in fact, it's chronic and persistent distress. They live with their abuser, they live with their perpetrators. And it is so hard for them to get through life living with this perpetrator and living with this constant distress, coming to school with chronic and persistent distress. And I want us to take note of that. So some symptoms of incest. Victims feel betrayed, of course, because someone who loves and someone who they trust is hurting them. Evolutionary theory will tell us our families are there to be there for us, to support us, for us to thrive, for us to exist and survive. Our families help us. That's sort of human nature. That's something we understand as human beings. And now when our family members hurt us, what are we to do? We feel powerless as victims. Victims feel powerless. When parents disbelieve them, when they say, Mommy and Daddy, my brother is hurting me, my sister is hurting me, this leaves an impact and a stain on survivors, because this type of invalidation affects their core. It affects their schema. A schema is a mental framework in which people live their lives, in which people believe certain beliefs about the world, about themselves, and about the future. Victims feel ashamed. Offenders often manipulate victims into believing that they consented or they enticed them. You sat on my lap, so you said, okay, it was okay. And you often find this in the treatment. When I do treatment of sex offenders, we definitely get to these core beliefs of really looking at these errors in thinking. And what we've seen, what the research has shown, are parents, primary authority figures in these children's lives. Their belief and their support has been shown to demonstrate a lot faster recovery and healing from trauma. So when kids come to you and they say, Mommy and Daddy, this happened, and you believe your child, and you take action, and you advocate for that child, it has shown to really promote a faster rate of recovery. Incest often causes much more damage than sexual abuse by strangers. And so I want to share with you a drawing of a 7-year-old patient who was sexually abused by his grandfather. And as a child psychologist, what I do when I first meet with kids, very rarely do I speak to them. And it's funny, because you think you're coming into therapy, of course you're going to talk a lot. But the language of kids, it's really not speech, it's not words. The language of a child is play, is art. So these are ways that they can express themselves. And in particular, what I really want us to notice, because we use drawings to evaluate, and we use it as a part of our projective interpretation. So when we look at this child, we see he appears very small on the page. And if you can see, there's a red, sort of frowny face. And in particular, this child experienced most of his abuse around this area of the body. And so he's very detached to this area of the body. It's not even associated. He's very sad, yes, but his mouth is no longer his. This is another image of a 5-year-old boy who was reportedly abused by his father. And this in particular, you can really see the pain. And you can sort of see some regression of the pictures, of the drawings, of the strokes. You see where the child's lying, you see excessive shading, and that's really anxiety that we see. So I want to talk about some of the effects of child sexual abuse. And now I want to talk about them within these domains. So a lot of times we see kids who are really emotionally dysregulated, and we see children with what we call in psychology a lot of emotional lability, meaning the moods are really up and down. And I want to make note of it that yes, teenagers, they do have fluctuations in mood, but what we see is a very different presentation. And I want us to not under-pathologize. I want us to be aware. So when we see kids, so sometimes I can give you an example. So maybe a kid pushed another kid, and by accident the kid fell. Now we're going to see a kid, the kid who was pushed down, beating the other kid to a pulp. So what we really see is a disproportionate level of an emotional display to something that was relatively innocuous. And we see heightened levels of fear and anxiety surrounding keeping the secret. We see anger, emotional constriction. A lot of times kids turn depression inward. So you'll see inhibitory behaviors where they constrict emotions. I've had an example of a patient where the child was abused and they experienced selective mutism. They stopped talking completely for 3 years. Whereas I've seen another child in therapy where they were so incredibly angry. So it really is a unique presentation, and it depends on the resiliency and the protective factors that child has. They're going to withdraw from normal activities. They're going to have persistent and continuous thoughts of suicide. They're going to engage in self-destructive behaviors and risk-taking behaviors primarily. And this is a significant peak in impulsivity, early substance use and criminal behaviors. And they're going to constantly be at odds with their sexual thoughts and behaviors and their fantasies. And very, very confused and not able to feel like they can fully navigate their world. This is another drawing of a 9-year-old boy who was abused by his stepfather. And in particular, this is one that's very painful to see. Because you can see that this child truly had agency. This child said, "Stop." So I want to talk about another domain, which is attention and concentration, and really cognitive dysregulation. So a lot of times, parents may come to me and say, "I think my kid has ADHD." And I'll say, "Okay, well, I'll do an evaluation, sure. But let's look a little deeper. Let's look at some more environmental variables, some biopsychosocial variables." A lot of times what we see with kids who have experienced incest or child sexual abuse, we see dissociative symptoms which look like they're not concentrating, but in fact they're experiencing dissociation, they're experiencing depersonalization. Depersonalization is really seeing, and you'll see it with some of the pictures that we're looking at. I want to show you, and even if we have to go back, I'll show you again. But depersonalization is experiencing our daily life, sort of looking outside of ourselves. It's not experiencing, it's not being in present, it's looking at our lives pass us by outside ourselves. And so I included some verbalizations of some of my teens and some of my kids. So they may say, "Teachers always say I don't hear their instructions and I don't know what's going on when they call me." Or they may have a lot of repression. Repression as a primary coping skill, where they'll say, "I hardly remember anything when I was younger." And what I see particularly in my cases in Trinidad is I see a lot of escapism. I see excessive gaming. And video gaming is something that I've done my dissertation on, something I'm very passionate about. And when we think about the domains and we think about the characteristics of gaming, we know that when we play video games, we feel mastery, we feel control, we feel autonomy. These people, these little people, they really have very, very, very little feelings of control. And they're always grasping at straws to feel in control, because they're often left feeling powerless and feeling small. Problems with self-perception. They feel a sense of ineffectiveness, a lack of agency, learned helplessness, shame, guilt, blaming oneself for not telling, confusion about their sexual feelings, their identity, and their desires, and attempting to make sense. A lot of times with regard, I use this example in particular with a patient of mine who, she just felt so damaged, so like she was nothing, and she felt like something was wrong with her because she was the one who was preyed upon, and not her other siblings. Not her other siblings. Why me? It was because something is wrong with me. Because I'm bad. I'm internally bad. And feeling, in particular for my teens, feeling a sense of alienation. No one understands me or ever will. And they really, adolescents go through the stages of, based on Erickson's stages, identity, self-identity versus role confusion. They really want to be identified with. They want people to understand, they want to belong. But when they've experienced child sexual abuse, very little times do they ever feel like they can belong or they can fit in. And of course, we see a minimization of traumatic experiences, because if we think about the symptoms of PTSD, PTSD is hypervigilance, which is constant physiological arousal and fears of anxiety, avoidance, and re-experiencing symptoms. So constant flashbacks, constant nightmares that we see with kids. So think about it. If you had to experience all of that on a daily basis, how exhausting would that be for you? How exhausting would life be for you? That a coping skill such as minimization, as we know, it's not healthy, but it helps them maintain. Interpersonal ineffectiveness. So the inability to trust. And I included a lot of the idioms that some of my kids say. People will stab you in the back no matter what. I don't have friends, I have acquaintances. Men are dogs and women can be just as bad. Problems relating to other kids. I don't bother to even tell my friends when I disagree with them or not. It's not worth it. They don't care. They've given up. They have no sense of agency. Re-victimization, and this is very important, this happens with adult survivors and some of my teen survivors too, where they put themselves in really unhealthy relationships where they go again and they're abused by their partners. And this is interesting to take note of, because when we see it in our schools, you may see a very bright young lady and you may say, what's going on? Why are you involving yourself in this crowd? Or with this particular partner? But it's understanding that it's the reenactment of trauma. It's all they know. It's what they consider as safe. And so this is why they engage in these negative relationships. And victimizing others. There's only a small percentage of people who've experienced child sexual abuse who reoffend and who victimize others. A lot of times there are misconceptions that when you've experienced child sexual abuse, you're definitely going to be an offender. That's not the case. Half the time, that's not the case. This is another drawing. This is the poem. You remember the poem that I shared with you guys in the beginning? This is her drawing. And I want us to know that this is a 21-year-old, and I want us to look at the drawing. It is very regressed if we think about it. And this is the effect that child sexual abuse has on someone. If we think about a drawing as a neuropsychological test, the drawing in particular, the markings, it is very regressed of an individual who is 21 years old. And if we really look at it, look at the way in which she views this situation happening. It's outside herself. And if we think about the hands, it's sort of like a spider. Somatization, and we're going to see this across the ages. You're going to see a lot of physical symptoms, disturbances in sleep, disturbances in appetite, disturbances in concentration and memory, and this is important to take note of as teachers because you're going to see this happen. You're going to see little kids who come to class and they're very tired, they're exhausted, they have very low energy, and they're going to have chronic experience of complaints of pain, a lot of school avoidance as well, poor immune system, the occurrence of sexually transmitted infections, pregnancy at a young age, difficulties walking or sitting, bruises or wounds. Please look out for these. Disordered eating, and I want to bring up this point because a lot of times I see kids with sexually with abuse who are abused in childhood, and a lot of times they come in with eating disorders. And if we think about OCD, obsessive compulsive disorder, if we think about anxiety in general, or we think about eating disorders, we really see that, again, that component of control. If I can control at least one thing in my life, if I can control what I eat, whether I choose to eat or not, such as anorexia nervosa, that is how I take charge of my life. That is how I take control back. And we see low academic performance and diminished motivation. Or school, we can see the both, two sides of the coin, right? So low academic performance, or we can see that school becomes a safe haven for them, or an escape. And what I want to note is so when I talked about a schema before, you remember the mental framework, the systems of meaning, so the meaning in which we place our lives in, the value systems. So oftentimes, victims of child sexual abuse have a foreshortened future. I'm not going to live for a long time anyways. Most teenagers have difficulties seeing within the sort of next year, right? That's a teen thing. But what we see with kids with trauma, we see a really exaggerated sense of foreshortened future. So I'm not going to live for long anyways. YOLO, you only live once, so I'm just going to do it anyways. I'm just going to self-medicate, whatever. I'm going to do it, doesn't matter. And problematic sustaining beliefs. So there is no justice for anyone in this world. Religion is just a bunch of lies. No one cares about college. It'll never amount to anything anyway. And the maladaptive view of the world, where if something could go wrong, for sure that's going to happen to me. And you don't get something for nothing. And this one in particular is really salient, I think, for most trauma survivors. And always expect the worst. So I wanted to definitely talk about this. So these are some of the beliefs that stop kids from telling, so that you can be aware of that. So fear of retaliation, no one will help, no one can help me, no one will believe me, there isn't enough evidence, maybe I misunderstood what my uncle or my brother or my sister did to me. I don't want to get them in trouble. And again, this has to do with the family system as well. Fear of the police and justice system. Now, if my family is in trouble with the police, there's no way I'm going to them. I don't feel safe with them. I don't think the justice system is fair anyways. Fear of disrupting relationships and negative evaluations of the family. In Trinidad in particular, I'm going to bring shame to my family. This is a disgrace. It's so taboo, I can't tell anybody. Fear of interrogation, fear of having to say their story again and again and again, which sometimes happens. Fear of criticism and blame, fear of being examined by a medical doctor, fear of being judged, and of course denial, shame, emotional shock, disbelief, depression, anger, guilt, powerlessness, and learned helplessness. So let's talk about some takeaway strategies for you guys as teachers and mental health practitioners. So what the research shows is that realizing, recognizing, and responding, being here today, being informed, you already have the power in your own hands. And so cultivate awareness in your school and agencies on every level, from fellow colleagues to shopkeepers to janitorial staff. And again, this is the trauma-informed care approach. And view trauma, in particular, specifically with the child's environment. And so we're running out of time, but I definitely wanted to talk about some barriers. So research shows that oftentimes teachers don't really have the resources to recognize some of these symptoms, and they feel reluctant to intrude on family privacy and consequences such as disturbing parent or teacher rapport. So how do we solve the problem? We remember our duty to do no harm. And a lot of times, a lot of teachers may feel something. They may get a sort of intuitive sense that something is wrong. Please trust your instinct, trust your gut. You are in this field because you are intuitive and you genuinely have passion and love for children. So do something, take action, and refer these children to the correct and the most appropriate professionals. And last but not least, I want us to talk about, as teachers, we need to be wary of compassion fatigue. A lot of times, when dealing with kids with trauma, it's important to know that you already have a heavy caseload or heavy things to do, a lot of documentation, a lot of things, planning, prep. So you're naturally going to be burnt out. But hearing stories from students who suffer with trauma, one may experience vicarious trauma. And so, of course, we need to be wary of compassion fatigue, some signs of compassion fatigue. I'm just going to let you guys review it really quick because I'm really out of time. So denial, chronic physical and emotional exhaustion, poor self-care, bottling up your emotions, frequent dissatisfaction with your work and life, very limited self-care, insomnia, and some interventions: practice self-compassion and gratitude, enhance your awareness with education, express what you need from your social support systems verbally, and try to find meaning in the suffering that you see. So I wanted to leave you this quote: unless someone like you cares a whole awful lot, nothing is going to get better. It is not. And that is from Dr. Seuss himself. Thank you very much. I really appreciate it.